So first of all, many thanks for inviting me to come and speak here today. It's a great pleasure and a great honour to come and talk to you. I hope that this presentation will answer some of your questions, and I'm here to answer as many as I can for the ones that I don't cover. I've put together a number of slides to act as a framework, but at the end of the day, this is your session, so please interrupt, ask questions, do as you like. If you can manage to ask a question where I can't answer or say something, then you've done something nobody else has ever managed. That doesn't mean it will always be bang on correct, it will be my opinion, okay? I'm going to talk through what I've tried to do here is cover the broad scope. So I'm going to cover what is CLL, for those who've been more recently diagnosed. Some of you might already know that, and if I'm telling you information that you feel like, I don't want to know this, or please can we just move on from that, I won't be offended. I know all of this stuff, this is for you. I'm going to talk about treatments, and that's the main focus of today. I'm going to try and put treatments into relevance and where we've come from and where we're going, then talk about where we're at the moment, what our options are, where we might be going next, and of course then the future and what might come. So I'm sure these sort of slides have been shown to you. CLL is the most common leukemia, so everybody's always fighting for a good title about their disease. So CLL is the most common blood disorder cancer, although is less common than lung cancer, breast cancer, etc., depending on the populations that you look at. It's about 1% of all cancers in the UK, so it's common. And if you take of all of the specialist leukemias, about 40% of the leukemias. Now, figures you've got to learn to interpret a little bit if you're going to read information, because although I'm saying here 40% of leukemias, even for a specialist like myself, it's not 40% of all of my time that I spend in medicine, okay? So, because a lot of people with CLL won't need my day-to-day attention, as opposed to somebody who I'm putting through intensive chemotherapy, they do, okay? About 3,500 new cases per year in the UK, so your CLLSA association should have plenty of budding candidates. And in the northeast, about 100 new people a year are diagnosed, of which most will not need treatment. And it is a case that CLL gets more common as you get older. We believe that's because our bodies are fantastic in keeping themselves young, if you like, rejuvenating. But that system, as it happens more and more and more, there's a greater chance for something going wrong somewhere. And cancers are just where that process of being perfect in making the new cells goes a little bit wrong, okay? Our immune systems are supposed to pick that up and get rid of bad things, but sometimes even that system breaks down, and that's what we believe happens in cancer, okay? We believe it all starts with one cell going fully rogue, and then cancer basically means that the growth and coordination of development of those cells goes wrong. So instead of producing the cells that you really need, that function in certain ways, you end up with more and more useless cells that eventually stop the good cells from working. That is what cancer is, okay? I've already heard a lot, and I hear it every day. People worry just because of this cancer word, okay? If I said to you that an infection is where a bug gets into your system and grows out of all control and eventually takes over good tissues so that they can't work anymore, actually there's a lot of similarities there. The only difference is we're all used to taking antibiotics and the infection getting better, okay? Similar is happening with cancer. Our treatments are getting better and better and better. So society needs to change in its attitude towards cancer and living with it. I've also made the point that There are an awful lot of things in medicine that we can't cure, but we help people to live with, whether that's heart disease, lung disease, liver disease, or whatever. Okay? So again, for many, cancer is something similar. I'm sure we'll get round to lots of questions about watch and wait and living under that sword of when's it all going to go wrong. But the reason we advocate watch and wait is because these cancer disorders are our own bodies. We can live quite happily with them. So if they're just sitting there and they're not stopping anything working properly, then no reason to live life in any different way. Okay? So it's we talk about all the time, glass half full, glass half empty. When you're diagnosed with cancer, you've got to get yourself very much into the camp of glass half full. That's easy for me to say, not so easy to do. So, first of all, you all want to know, what is CLL? Well, this is CLL. All these cells in here, these are lymphocytes. They've got a classic morphology. So when I look down a microscope, these are the things that I'm looking to see. They are small lymphocytes where the majority of the cell is filled by the nucleus, and they've got very little cytoplasm. So basically, the nucleus is the brain of the cell that tells the rest of it how to work, and if you like, the equivalent of our arms and legs of the cell are in the rest of that, what we call cytoplasm. We used to diagnose CLL exactly from this, from a microscope, but what we've learned over time is that actually just doing it by recognizing with our eyes is fantastically unreliable. So I'll show you in a second how we do diagnose things. But basically, CLL is a number of identical cells that are accumulating because they do not die properly as they're supposed to, okay? As opposed to some other cancers where the worry is always they're growing really quickly. What we believe in CLL is that cells don't die properly. So if you think of a bath, the water level, if you haven't got the plug in the socket, depends upon how much you've got that plug covered, as in how much water you lose, or how quick you've got the tap on. If you've got something that's very fast growing, like acute leukemia, then that's the equivalent of having the tap full on, because it grows very, very quickly. Whereas CLL, it doesn't grow so quick, but the cells don't die properly. So it's a bit like covering the plug, and it makes the water rise. Okay? That's the way we conceptualize these things. So that's why we have to try and use different approaches to treating it, because obviously some drugs that we use are very good at attacking cells that grow quickly. Other drugs are better affected by drugs that don't need them to be growing so quickly. Exactly what goes on and why people develop CLL is still a matter of great research. What we do believe is things go wrong and these cells stop dying for various reasons. But what we think, in the old days, what we used to believe is that the cells parked themselves somewhere and almost hid from the immune system. And so when people got big glands and things, we used to think that was a static process. Whereas the current beliefs is actually these CLL cells are still moving around our body because that's what our immune system does. It's a whole patrolling system that picks up invaders and then attacks them to get rid of them, okay? What we believe in CLL is that those cells move around, they go into the lymphocytes, they get little messages in there that say, don't die, stay with us, and then they move off into the blood again, okay? There are some risk factors, so people who are exposed to radiation, smoking, all these things, there are slightly higher incidences of CLL, but there isn't clear cut. If you do this, you'll get CLL. And what we believe is, actually, between different races, there's quite a similar incidence of CLL. What we do know, though, if you go to registries, some countries it appears more common than others, and we believe that that is actually down to recording rather than there's a fundamental difference in the diseases or what they're at risk of. And then lastly with CLL, cure is not possible for the great majority, so all of our treatments are aimed at living with the disease, okay? Perhaps in the future that may change, and there's lots of exciting things that are going on that I hope that is different in the future, but more important than anything, in any of the cancer realms, we do not have tests that say it is all gone now, okay? We talk about remissions. Remissions means we can't see it anymore. Sometimes we have more fancy tests to pick up lower amounts of disease, this thing called MRD, measurable residual disease. But we don't have tests that say you're cured. So again, that's back to this glass half empty, glass half full. If you have a treatment and we say you're in remission now, what it means is the longer it goes without seeing it, the more hopeful we are that your disease is going to behave in a benign way. Okay? That's often a very difficult thing that people struggle to come to terms with through the clinics. So, if we take CLL as a whole, so remember when we look at studies always look at populations, okay? So me as a trial person, when I'm looking at a study, I'm not thinking about any individual, I'm grouping everybody together and I'm trying to look for patterns and trends of what happens to the great majority. When you sit in front of me, it's all about you, okay? And I'm trying to apply every bit of knowledge that I've got to make sure you get the best. So it may be that in a trial, a certain drug didn't work that well for 50%, but in you, it's given you remission. That's a fantastic drug to you, okay? Doesn't matter what it says in the trial, it's worked. So it's important to understand these differences, again, when you're having your discussions, when you're thinking about things, when you're reading about things. So here, the whole group of CLL, more than 80% of people, we will pick it up on a blood test. Nowadays, in my laboratory alone, we do something like 2,000 to 3,000 blood counts a day. Okay, in our laboratory, it covers 3 hospitals. We're doing blood tests for GPs and all out in the community. So we pick up lots and lots of things, okay? Lots of you will all say, if you pick up this and it's not going to affect me, why do you tell me? And that's absolutely true. And if it was 30 years ago, we wouldn't have told you. And even sometimes pragmatically, we might have somebody where we pick up in a 90-year-old that he's got a small increase in his lymphocytes, and we do exactly as you asked. We don't say to the GP, this is probably CLL. We say, the lymphocytes are slightly high here. Check a blood count again in 3 months or 6 months or whatever we think is appropriate. Okay? But what we've learned from the past is, if we're not honest with you, you start to become worried we're never telling you the truth. And therefore we cause you more anxiety because you're worried that we're not telling you that truth. So nowadays, the modern way of medicine is we tell you everything, okay? Unless you come forward and say, actually, I don't want to know. We always respect autonomy. So 80% of CLL, no problems whatsoever. Many people who are elderly, okay, that's a terrible term to use, and I'm a bit frightened using it on a stage where you might shoot me. But we have to think about how long are you going to live? And that's an unknown quantity for us all. Death is the only guaranteed thing to happen to all of us, but none of us like talking about it, and none of us like thinking about it, okay? So I'm going to show you some things slightly later on that, one, doctors are quite bad at predicting it, and two, that, how would I put this? That doctors will often say to you that at this time you don't need treatment and therefore your lifetime risk of dying from CLL or your lifetime risk of dying is not changed by this diagnosis. And I say these words all of the time. But we do know there is data that if you take everybody on average, if you've got CLL, you will die sooner. Okay? Which is why we're working so hard on treatments that we can give to people who are older or might have other problems because they're better tolerated. And that's a major improvement. So again, when you read these sort of things, they are data from years ago. When we had treatments for CLL, the standard treatment for CLL used to be chlorambucil. When I was a registrar training, the standard for CLL was, here's some tablets, you take them for a few days each month for about 6 months, and we'll need to treat you again in about a year. We'll treat you again until as long as it keeps working, but at some point it'll stop working and then you'll die from it. Nowadays, we've got a whole load of things to offer you. It's fantastic. Okay? So, all sorts of benefits coming out in this disease. But if you haven't got a problem from this CLL, you are still better staying away from the treatments, because there isn't a treatment that we can offer that doesn't have side effects. We all know, even if you take antibiotics, quite often you feel worse on antibiotics than you do if you're on them. Off them, sorry. Okay? Whether that's giving you bowel upset or whether it's just making you feel under the weather, whatever it is, there's generally a price to pay for any medication. So we only give out treatments if we are very clear that it is in your benefit. For those where it is more of a problem, CLL can cause lumps and bumps, most commonly in the lymph glands. So the lymph glands that you can feel are your neck, under your arms, in your groins, okay? You've got lots and lots of glands elsewhere, all over your body, but generally they're deeper in so you can't feel them, okay? So that's why we use those areas to assess you. Livers and spleens are commonly get bigger with CLL, particularly the spleen more than the liver, but can be either. So I'm going to talk in a second about staging disease, that's important. We believe that CLL, it's disturbing how the immune system works, so everybody is more at risk of infections. But there is a range of that. There are some people who come to me and they're absolutely plagued with infections and I have to try and do things about that. There are other people, they wouldn't know they were any different from anyone else. Okay? So it's a risk and it's one of the things that we assess for. B symptoms, constitutional symptoms. We get loads of referrals from GPs saying, this person's got sweats, can you check them out for cancers? And loads of the times we do scans and we don't find anything. So 2 points from that, there are loads of things that cause fevers and sweats, not always cancers. And usually when you get fevers and sweats, it's a measure that there's a lot of disease around that probably does need treatment, which is why we're trying to pick it up here, okay? But if you've got early stage CLL and you've got fevers and sweats and we can't detect quite a lot of disease, it's probably other things, okay? So don't worry about that necessarily. And then profound lethargy, tiredness. I make a joke in nearly every clinic that I do because every patient who walks through the door, they say, I feel tired, doc. I feel dreadful, doc. I can't be bothered to do things. And my reply to that is, we're all tired, including the doctors, okay? That isn't because I don't care. It's because tiredness gives me absolutely no direction to help find out what is causing it, okay? There isn't anything in a medical textbook that doesn't include tiredness within the symptom list, okay? And for so-called normal people, they're generally tired too. So I'm glad to hear that you're all feeling tired. I'll commiserate with you. I'll even join you and say, God, you know, I feel knackered too. How are we going to get through this clinic? But it's not going to help me get to the bottom of problems, all right? So there is a question up here straight away asking about the difference between CLL and SLL. So I'm going to answer it here because this is what it is. So when we are trying to investigate diseases, we want to try and make the population that we recruit to analyse as similar as possible so we know we're trying to deal with the same thing, okay? So therefore, we try to define as closely as we can what a disease means. So every doctor that comes along, we should all be talking about the same thing. Okay? Lymphomas, of which CLL is one of the many types, it's been reclassified over the last few decades 100 times. Okay? And what they've realized, as we've got better and better at detecting different things, is there used to be a disease called chronic lymphocytic leukemia and small lymphocytic lymphoma, and we used to regard them as two completely separate things. And now we believe actually they're the same disease, but it's just how they're affecting the body. Okay? So chronic lymphocytic leukemia it's got the things that we need to diagnose it, which is this stuff here at the bottom. So we use fancy markers on the cells that we do on a test called a flow cytometer. And basically we stick antibodies onto the cells and we look at the B cells. And B cells shouldn't express this molecule called CD5. They shouldn't express this CD23 because they're T cell markers. FMC7 shouldn't be there, okay, in CLL, so we don't want to see that. We use antibody molecules, so lymphocytes. We have antibodies in our system that go around and bind to things and help our immune system recognize it. We also have antibodies bound to our B cells, which is the type of lymphocytes that get affected by CLL. So they're sticking on the surface, and it's how they go around and how they recognize things, a bit like our eyes and ears. And so normally what should happen in a healthy immune system is all of those cells are different. They've all got different looking antibodies on the surface. But when we look at them under these special tests, CLL cells have all got identical ones. So again, we're looking here for immunoglobulin that's all the same, what we call clonal, and there shouldn't be too much of it in CLL, and then this other molecule here. So everybody that comes along, we identify you as having too many lymphocytes, we send it off for this fancy test, and we get a score back according to this, and if you scored 4 or 5 on this scheme, that makes you a diagnosis of CLL. Okay? Whether or not you are CLL with only cells in the blood, or whether you've got lots of lymphocytes, or whether your liver and spleen's big, or whether anything else is affected by that CLL, it doesn't matter, because I call it CLL because there's more than 5 times 10 to the 9 lymphocytes in your blood that I can see on that test. If I can't see more than 5 times 10 to the 9 lymphocytes in your peripheral blood, then we call it small lymphocytic lymphoma. Okay? So lymphoma is lumpy disease, CLL is leukemia, which means it's in the blood disease, and then they obviously overlap. So we had to work out a way of how we're going to fit them into those different groups. So the only difference is that number in the peripheral blood. Okay? Staging. Have you all been told the stage of your CLL? Does everybody fully understand that? If I put a lot of doctors who don't have special interest in CLL, they'll all know these staging systems, but their clarity on exactly what they mean and what they do will be less good. Okay? Because CLL has its own staging system that is different from other diseases, from other lymphomas, and generally hematology cancers have different staging systems from other normal cancers, or organ-related cancers. Okay? So, Ryan Binet, 2 very famous hematologists. Conti Rai is a New York hematologist who is still professor of, I can't remember the name of the hospital in New York, but he's about 90-something now, still goes to all the major meetings, falls asleep, and then asks the most amazing questions to whoever's presenting. Binay, he's an Italian, and there was a really nice thing at one of the big meetings last year where they brought them together and they gave them a prize together for creating these staging systems, which has helped us classify patients for years and years and years. So, the most common one that we use is actually Binay because it's a bit more simple. A, B, and C, okay? And it basically means to have the CLL, you've got to have the lymphocytes in the blood. That's the number one. It's a hierarchical diagnosis, if you like. So you've got to have that. So to be stage A, which is the earliest, you must have lymphocytes. And then if you don't have enlarged lymph glands, then we call you stage A. You must have more than 3 to get up to the next level. But what it means is there are 5 lymphoid areas, okay? So neck, under the arms, in the groins, liver and spleen. The thing that most clinicians get wrong is they believe that each one on the side of the neck makes a change to that. So they say, if you've got lymph nodes on this side and a lymph node on that side, that counts as 2. Strictly, it's not supposed to. Okay? So you're supposed to have 1, 2, or 3, or neck, liver and spleen, or under your arms, liver and spleen, to make it to be stage B. Stage C is defined as your bone marrow is being compromised, so the number for your red blood cells that carry the oxygen around, platelets that plug holes and stop you bleeding, are compromised. Okay? The reason why this is important, in all trials, we always say that it's stage B and stage C that we're treating. There should only be a very small number of people who are demonstrating very rapidly growing disease with stage A that ever get into a trial. Okay? Because generally, early stage disease you can live with very happily. All right? Binay, effectively the same, it's just classified slightly differently, okay, and you can see from what's written down there the minor differences.
If after you've been diagnosed and you've been staged, and after treatment, those measures have changed, does that mean that you've reverted?
Yes.
So therefore you're at a different stage post-treatment.
So when you're diagnosed, you should have a stage at your diagnosis. If you're put under watch and wait, each time you're assessed, they should be thinking about your staging, okay? And if, basically at the point of needing treatment, you must have demonstrated that you have progressed by going through to a higher stage. Then you have treatment, where, if you like, resetting the disease, and you go back, and then we follow it again, and then when you get to a stage that needs treatment again, we give treatment, and then back again. Okay? Why it's also really important, and it has come out really, I was just reading a paper this morning related to treatments. So when we do trials, and when the drug companies want to assess how good the new drug is, I mentioned to someone before that CLL is generally quite a slow-growing disease. So if you wait for the full natural course of CLL, so what we should be looking at is, here's the disease, needs treatment, we treat it, then we watch it again, wait until it needs treatment again, treat it again, what's going to happen next? That takes a massive amount of time for many patients, okay? And so there's only time in a clinician's career for CLL to only do 1 or 2 trials if we go on that. So nowadays we're constantly looking for what surrogate markers can we use to pick up either problems in people or what can we use to show that this drug's really good and we don't have to necessarily wait for all of that information. Another way round is we do lots of CT scans. Nowadays it's really common in all of the lymphomas in the trials. We do CT scans every 3 months, and what they set the trial is, they say, right, you've had your response, here's your treatment, and we'll watch that, but as soon as those lymph nodes start getting any bigger, that's it, the treatment's failed. So it's a CT scan decided how long has that treatment worked for, not the same as time to next treatment. So again, I'm mentioning this in case you go reading things in journals, because it's very difficult to get on top of. You've got lots of different terms that are used. Event-free survival, progression-free survival, time to next treatment, progressive disease on imaging, and so on and so on. So whenever you're trying to interpret a paper, you've got to be very aware of what the investigators have used to make their assessments, and they're not always standard. Okay? So I give you this example of what I was reading this morning. The CLL14 trial, CLL11 trial showed that chlorambucil in combination with obinutuzumab gave progression-free survival, so detectable clinical disease, were progressing in the patient of nearly 30 months. Okay? But in this study that was being reported, they noticed a change in only 19 months. Okay? But the difference was, the paper that I was reading this morning looked for progression of disease on the CT scan. So they detected a change nearly 12 months sooner because they were using CT scan, and they can look at all of the things deep inside, which obviously when you make clinical examination, you can't. So you've got one trial here that's saying this treatment works here, but it only works for under 2 years, and another trial here that says it's working for nearly 3 years, but actually the same treatment. So everybody's sitting around saying, actually, is that treatment as good as that first trial reported? Well, yes, it probably is. It's just that people haven't interpreted it in the same way. And this is what we suffer in medicine all of the time. How do you truly make good comparisons? So for you, when you're asking clinicians and things, you've got to put your faith in those clinicians that they understand the information behind things. And drug companies, we as so-called experts, spend an awful lot of our time trying to make sure those clinicians do understand what's right, and that's why we write the guidelines and say what treatments should be used. Okay? But it's a complex game.
Excuse me, could I just raise a point on staging? When I was diagnosed, I was told I was at stage 1.
Yeah.
And yet, by that raised staging, sorry, my eyes aren't very good, I have no enlarged lymph nodes. Which is the preferred scale that's used given diagnoses in this country? Can you see my point?
Absolutely. And you are demonstrating exactly what the point I was trying to make. So if you've only got raised lymphocytes in your blood and you haven't got enlarged lymph nodes, you are stage 0. Or, so you are not stage 1 if you do not have enlarged lymph nodes. So you've been told wrongly. Obviously, I can't dispute whether, without coming in and examining you, I don't know. But do you understand what I mean? And this is where people get mixed up, because they get mixed up between these two systems because they're subtly different. But you are stage A, not stage 1, if they're using bin stage, or you are stage 0 by the RAI. Okay? Supportive care comes at every stage, wherever you are. Supportive care just means the things that you need or don't need, okay? With CLL, I've said to you that there is an increased risk of infection. So what can we do to try and reduce infections? Flu is a terrible thing that goes around our communities. You should all be having flu vaccines. Everybody's got a story about how they've had a terrible reaction to the flu vaccine. They don't want it ever again. But the truth is, it saves an awful lot of people's lives, and any minor reactions that you get, and you may not class them as minor, but what I'm talking about is people that I send to intensive care and things because they've got terrible flu. If you have the flu vaccines, and we all have that herd immunity that stops that flu getting a hold, it is a benefit to us all. So we should all be going for flu vaccines unless you truly do have an allergy or a definite contraindication to having it. It is in your benefit, okay? Common bugs that cause pneumonia is this stuff called pneumococcus or Haemophilus influenzae type B. Again, we have vaccines against those. So if they get in there, your GP surgery can vaccinate against that, which we should be making recommendations for you through the clinics. And then over time, if we're worried, we can always check your immunity and revaccinate you if needed. There is that risk for you that obviously, I'm saying your immune system's impaired with vaccines, you might not respond as well to a vaccine as somebody with a normal immune system. But the truth of it is, it's still worth any benefit that you get out of it, and you're unlikely to come to harm from it. So we recommend it for everyone. Sometimes, as part of CLL, the lack of that control of the immune system gets disrupted, and sometimes we get complications of that, where the immune system turns against our other blood cells, the red blood cells or the platelets. And that's what we call autoimmune cytopenias. So the blood counts go low, not because the bone marrow is full of disease and it's failing, it's because the immune system is consuming up the blood cells and the bone marrow can't replace them, okay? We do not judge that as needing primary treatment of the CLL. It needs treatment of the immune system to control that. But for some people, even with trying to control the immune system, doesn't always work, and in those we know that if we then go on and treat the CLL, often we can bring it under control. But if it's not a primary reason for treating your CLL. And then antimicrobial and prophylaxis and immunoglobulin. So prophylaxis is preventative treatment for some people who get lots of problems with infections, particularly people with lung disease and things. Sometimes we use antibiotics. CLL causes a flattening of your antibody production, and we always used to give intravenous immunoglobulin. It requires coming to the hospital once a month for an infusion into you to replace the antibodies you can't make sometimes. But there are national shortages of that, and it's also blood products, which we prefer not to give you if there isn't an alternative. So increasingly now, the current guidance is if you're getting problems with infections, we should try antibiotics. If antibiotics don't work, then we try immunoglobulin. Okay? Yes?
Is that plus one the same as IVIG?
Yes.
Thank you.
And it's more common in people who've got to the stage of needing treatment. Has to be said, but not always. Shingles vaccine. The shingles vaccine that's currently available in the UK is a live vaccine. Many other vaccines, like the flu vaccine, is a dead vaccine, an inactivated vaccine. Sometimes we talk about attenuated vaccines. Shingles vaccine was brought in initially for people over the age of 70, and it was being given to everyone because shingles is a horrible, nasty thing to get, and for some people they can get terrible postherpetic neuralgia, which is pain in the sites of where you've got shingles. But what we found was in patients with CLL, they did get a nasty reactivation of the virus even when the vaccine was used. Now, it's impossible to predict who is going to be affected there. Of course, people with more advanced CLL are probably more at risk than early stage, but UK experience has been even some people with very early stage CLL, they've had nasty experiences with the vaccine. So we've just said across the board, nobody with CLL should get the live, currently recommended shingles vaccine, okay? If you've had it and you didn't have any problems, you've beat the system, that's fine. You don't need to go rushing back and caution somebody over the head about it. But the systems going forward should be shingles vaccine shouldn't be offered to you if you've got CLL. There is a new vaccine that is far better. It's a dead vaccine, so it's safe for people with CLL. It's called Shingrix. It's been approved in America, but so far it's not funded in the UK. It has been approved by the European Medicine Association as well. We're waiting to hear at some point that will filter through. At the moment, though, if you want it, you've got to pay for it privately, and I think it's about £400. There's GP surgeries in Hammersmith, so I was told the other day at a meeting, and mainly around the London area that are offering it. I don't know of anyone locally that is. So, treatment. This is a list of the currently funded treatments for CLL. So I said to you, if you'd come 20 years ago or whatever, chlorambucil was pretty much all there was, and then it's expanded, and as I'll show you on the graph next, this is the rate of development, and more is coming along quicker and quicker. So 1950 was when we started with chemotherapies, which was basically melphalan was the first chemotherapy agent that was developed following the war and the use of mustard gas. Chlorambucil wasn't far behind that as another what we call alkylating agent. It's not important to you, but is relevant to how it works. And then the next major breakthrough for CLL was not until the 1990s, where we got fludarabine and then found better ways to use that. Campath was developed just when I was a registrar. When I worked at the Royal Free in London as a trainee, we were making our own style of Campath at the time and starting to use that in our transplants. Campath, great drug, and very useful for some people, but the people who make it decided that there was more money to be made in treating multiple sclerosis, and so they still made it available to hematology patients, and we can get access to it free through their patient access schemes. But by doing the system that they have, it no longer falls within sufficient governance, and it's no longer able to be used in trials. So literally, it's a drug that's just died in its use in CLL. It's a good drug. It does have very good effects, but the effects are short-lived. And another reason why it's died out is we've just got better things now. So we're concentrating on other things. Fludarabine, cyclophosphamide, and rituximab, CLL8 trial by the Germans on the top of other trials alongside it, but that was the big randomized trial that proved that should be the gold standard of treatment, was 2003-ish. And then just post-2008 and in the last decade, we've got all of these treatments, with the most recent funding decision, venetoclax and rituximab, approved on the back of the Murano trial, and then there are other combinations that are going to follow it shortly with venetoclax and obinutuzumab and ibrutinib and obinutuzumab and all sorts that are being considered. So when do you need treatment? This is always a question. So again, talking about these trials, I always think it's amusing. You're always told that you should never rely upon a trial protocol to be the main information of how you treat patients. But the truth is, all of our evidence for how we treat patients is brought together through trials, and therefore the standards of what we use within trials have transferred across into our care. All right? So these are the internationally agreed working criteria the IWCLL is the International Working Party for the Treatment of CLL, and this is consensus statement from 2008 criteria. So you need treatment if you've got evidence of bone marrow failure, that's stage C disease or stage 3 and 4 disease if you're using the RI system, which is basically you're getting problems with anemia. We define that usually as a hemoglobin less than 100 grams per litre, or your platelets falling below 100 grams per litre, caused by bone marrow failure. If you've got lymph nodes that are really big, unsightly, cause you difficulty in some way, or they're bigger than 6 centimetres, or they're getting larger, that's another indication for treatment. Very big lymph nodes, even if they're not symptomatic, we treat them, so bigger than 10 centimetres. If the lymphocyte count in your blood is doubling over a period of 2 or 3 months, then again that tells us that the disease is behaving in quite an aggressive way. There's no point in waiting until you've got more and more of this disease around. We need to get on in there and get it sorted. If you've got these immune system complications that turns around your other blood cells and it doesn't respond to our standard treatments, that's another indication for treatment. And then if for whatever other reason you are feeling just dreadful with your disease, you can no longer carry on in a reasonable fashion, and we can't find any other reason to explain that, again, that's an indication for treatment. But that is only proved if we treat you and it gets better and you feel better. Does that make sense? Yeah? So then what do we consider when we're deciding on treatments? Difficult, so medicine's an art rather than a true science, if you like, as in if it's this, you do that, that and that. We try to help people through their decisions by guidelines, saying look for this, look for that. But quite often it's putting a number of factors together. So the sorts of things that we're interested in, depending on where you are on your treatment journey, we might have done things called cytogenetics to look for this terrible P53 mutation disease, where, again, those cells have something that goes wrong with a system that normally destroys those cells, and we know that they classically do not respond well to the traditional chemotherapy treatments. So before we had the new targeted therapies, people with TP53, deleted or mutated disease, had a much worse outlook, okay? With modern day treatments, that is getting an awful lot better. Another big thing that came through quite early on, again, just when I was at finishing med school, this differentiation of CLL into 2 main groups, whether your genes for making the antibodies related to your CLL show a pattern of mature cells that are nice and developed, or whether they're very immature cells. So what gets called mutated, that means mature, so that basically the genes have moved around to change how the antibodies structure so that they're better at identifying certain targets, or whether they're unmutated and very immature, okay? And if this is defined as to have unmutated immunoglobulin genes, you've got to have greater than 98% homology with your constitutional genome. Does anybody know what that means? I do. It means that basically they take a sample of you from wherever, usually they use your other blood cells, and they see what genes you were born with. And then they compare it to some of the CLL cells, and they use this arbitrary cutoff of if they look 98% or greater identical, and there's no change in that gene pattern, then it's called unmutated. Everything else is mutated, okay? So that's almost down to the point of if it's 98.1, you are unmutated. If you are 97.9, you are mutated. Because medicine has to form a dividing line somewhere. Okay? So everybody thinks that we've got nice, clear-cut information all of the time, but actually, usually there's spectrums of everything. Okay? But that's what we do. Then we think of other things. So there are other markers that we can look at. Things that we look at in your blood tests, thing called beta-2 microglobulin. If you've had previous treatments, how well did you respond to them? If we gave you certain treatments, did the treatment only last for a year or did it last for 10 years? And then people make careers out of trying to find different markers that pick out different patient groups. So a test we don't use very often nowadays, thymidine kinase, lymphocyte doubling time is LDT, LDH is lactate dehydrogenase, another blood test that we sometimes do. So they're there, okay? And sometimes we can use them to help us predict things. You as an individual are really important. Your age, whether you're male or female, because sometimes outcomes in trials show that sometimes men do much better than women. Performance status increasingly comes to it. Who knows what their performance status is? Have you heard of that? It's basically how fit and active you are. Okay? We define it nowadays most commonly as ECOG, okay, the European Collaborative Oncology Group scale, and it goes 0 to 5. 0 is really good, 5's bad. Does anybody know what 5 means? Dead. Yeah, absolutely. 0 is great. Okay? But great is not poorly, is very poorly defined. So it means you're doing your normal thing. So if you're a lazy git and you just watch sport all day, and I'm out there on my bike every day trying to stay fit as everything, we're both 0. So clinical assessment goes beyond that, obviously. Comorbidities, Rye staging, BNA staging is in that of things that we look at. Genetic markers, as I've talked about. So again, TP53 or 17p deletion is the biggest overarching thing that we look at of cytogenetics and always gets mentioned. Why does it get mentioned? Is anybody at the point of needing their first line treatment? Or just been through that recently? So that's so important because if you are 17p deleted or you've got a TP53 mutation, you're entitled to ibrutinib first line and you don't get standard chemotherapy first, okay? But that's the only cytogenetic abnormality that currently changes treatment, okay? For everyone else, we know that it's a predictor of what the disease may behave like. Interestingly, 11q was another thing that used to be a bad thing. And when we looked at people who had fludarabine and cyclophosphamide treatment, the people with 11q relapsed sooner. Then we added rituximab, and now they seem to do just the same as if you didn't have 11q. So things also change, and this is what we're also finding with the new targeted therapies, that actually people with 17p used to do badly, but now using targeted therapies, they're doing much, much better. Okay? So it's a dynamic process. And then there are even other things that we can do, those protein and RNA expressions. Sufficient for you to know is there's multiple things that we look at. And this is really putting that together. Have you all heard of Professor Halleck? He's an international guru of CLL. He runs the German CLL study group, he was the chief investigator of the German CLL8 trial as well as many other trials. But the reason why I asked is he's often very well known for this, looking at how fit people are and using it to decide upon what sort of treatments you might consider. So he grouped people into 3 categories: go, slow go, no go. Okay? So that, we're always trying to make things easier for doctors, get it into their heads, what sort of things should they remember. So that's not meant to be inflammatory or deflammatory or whichever way around you put that. But the idea of that is go, you're a fit person, no other major problems that we need to think about. Slow go, you might be an older individual with multiple other problems where we've got to think about taking those other problems into consideration. And then unfortunately we get other people who are diagnosed and they're in a really bad way for whatever reasons, and actually treatment isn't appropriate. Okay? So all of these things have to be put together. It is recognised that CLL is predominantly a disease of older people. Most people are over 70. For a long time, all of the trials that were being done in CLL were in young individuals under 60. So with that recognition now, there is this, many more studies that are being designed where they use this CLLSA score, comorbidity index, I can't remember what the RS stands for, but basically is trying to separate out people who have other problems such as kidney problems or just generally fit because other things aren't quite working as well, much higher risk of falls and things, and to pick up that group and say, well, actually, if we give those people the most intensive treatments, we're actually going to shorten their lives by those treatments because they're so poisonous and they're unlikely to recover from them. So actually, we need different styles of treatment for them. Let's do our trials, and that's where there's major breakthroughs really being made just at the moment. Life expectancy, reduced organ function, other things that are going wrong. Crucially important in what we're deciding, because if you are coming to me with, and you're young with CLL, you basically want from me, I want to live forever with this disease. What are you going to throw at me? I don't mind if you make me feel absolutely rubbish for the next few months, as long as you can give me extended life and time with this. So these are the ones who at the moment we're really trying to put together. Can we find ways to cure? Can we use the different treatments that we've got? All of the different things that might be on offer. Then there's some in the middle. Then there's at the other end of the market where it's not so good, but actually you know that life is already impaired with other things. CLLs come on top, but what can you offer me so I can get back to my reasonable living, so that I can get back to the life that I was quite enjoying? Thank you. I don't want something that's really going to make me feel dreadful. I want to live out my life with quality of life. So quality of life, to me as a doctor, is equally as important as number of years. And sometimes we can't offer both. And you are absolutely crucial in making those decisions. Because if you come to me and you're 75 and you're very fit and you say to me, I want FCR chemotherapy at the moment, and I'm willing to take the risks of that treatment, and I know you tell me that there's lots of poisonous effects related to that, but I'm strong and I'll get through it, I'll give you the treatment. But then if you get lots of complications, or even worse, it shortens your life from that treatment, wasn't a good decision. And these are the sorts of balances that we're trying to make. Okay? So what is the major breakthrough at the moment is we've got options. So you thinking about what you want from your treatment is very important. Okay? The other thing, as I said to you, is doctors, I would say now, my parents are over 70. They looked as fit to me as probably I am, to be honest. We used to say 70 was a bit of a dividing line of, we're not ageist, we don't do anything on age, but in general, people over 70 in the past generally had lots of other things going. I would say now the general impression in medicine is 80 is the new 70. Lots of people are living through their 70s and not really having that many problems. Then more commonly things start cropping up in 80s. But our wards, my clinics, I've got 90-year-olds, I've got the odd 100-year-old, so people are doing better. I live next to a cemetery. It is interesting to see that even when I walk around our cemetery, there are some people in that cemetery from the 30s and 40s that lived to 70 and 80, but there are an awful lot more who only lived to their 30s and 40s. So the major difference that's happening at the moment is a greater proportion of people are living to old age than we ever did in the past through the benefits of better health generally and medicines. Okay, we're almost done. So, to make this clear here, life expectancy is 88 in the UK. Obviously, that does change around by regions, and some parts of Gateshead, it's nowhere near that if you look at statistics. But generally, there's a funny thing for statistics that if you're 60, your chances of getting to 70 are lower. I think this is right, or roughly, the sentiment is right anyway, but if you get to 70, your chances of getting to 80 are much, much better. Funny statistic things. This is the common thing and what dispels. So we commonly say to patients, if you're diagnosed in your older years with CLL, so in theory, there's less time that you're going to have that disease in your lifetime. It may well be that your lifetime prognosis is not changed by having CLL. But the truth is, if you take things properly, if you're diagnosed at 55, on these statistics taken from 2010, which is looking at treatments prior to that, obviously with people with CLL didn't do as good as the populations who didn't have CLL. Slightly older too. So, current first-line treatments. At the moment, we are chemotherapy-based for first-line treatments. That is likely to change in the times to come. We're just waiting on the studies and the funding approvals to follow that. But at the moment, FCR chemotherapy is the gold standard, and if you're fit enough for it, then that's the treatment you should go for. Bendamustine, pretty close. Chlorambucil is another very good treatment, but only when it's combined with antibody treatment. But whatever we do, whenever we add something extra, there's always a little bit of price to pay. So there are some people where chlorambucil should be used on its own. And then lastly, the targeted diseases, but for first-line treatment, so that's the first treatment that you receive, you've only got the option of ibrutinib and idelalisib if you've got this 17p deleted disease. The excitement about cure and why we're all chasing cure is this data from the CLL8 trial, and it also came out of MD Anderson. These are survival curves. I've tried not to put lots of survival curves into the presentation because understanding them can be difficult, but what we're looking for with survival curves to get excited is when we see flat lines. And what this showed here is that where you've got mutated CLL, mutated immunoglobulin genes, CLL, and you give FCR treatment, there are a proportion of people who seem to stop relapsing, and we're hopeful that they might be cured. And this is with 16 years of follow-up. Okay? So at the moment, that's the only group who we think have a good chance of potentially being cured with current treatments. This is a trial that just shows bendamustine treatment is not quite as good as FCR, but pretty close. So if your clinician says to you, I think you'd be better off going for bendamustine because it's a bit easier than FCR, that's probably good advice. Chlorambucil and obinutuzumab is definitely not as powerful as a treatment as FCR or bendamustine, but it's an awful lot more tolerable. And if you're in your 80s, this is the really important data from it, that the 50% of people who had that treatment were almost going 4 to 5 years before they needed any more treatment. So you get a very tolerable, gentle treatment where you may never need any more treatment in your life, as opposed to going through much stronger treatment that may harm you. Okay? So these sort of treatments in the right people are definitely the right thing to go for. Second line treatment. Up until relatively recently, it was, if chemotherapy worked for you before, we should be using it again. Possibly stepping up the intensity if it didn't work very well. But now we know we've got enough data that says the targeted agents are better. So pretty much now, if you're up for second line treatment, you should be being offered targeted therapies. That's what we're putting into guidelines. So targeted therapies, this is a diagram that shows lots of fancy molecules. These are about the signaling within the cells and how it talks to itself to make sure the right things happen. And these targeted therapies go right into the center of the cells and disrupt that. And it disrupts the signaling that keeps the cells alive, so they die. This was the first trial that showed the benefits of ibrutinib, and the great majority of patients were having this treatment as second-line treatment or subsequent line treatment. And obviously it worked, but it's not perfect. But this is what's feeding that should we be using these drugs earlier and earlier, because if we use them earlier, they have better effects. And this is the sort of evidence that we're using to show that previously groups that we could identify that didn't do as well with traditional chemotherapy, with these new targeted therapies, they're doing pretty much as well. Okay, this is the mutated and the unmutated group, and those lines are pretty much overlapping. But what it's saying is, they're not wonder drugs, they don't solve all of our problems. We still need to work out how best to use all of these different armaments that we've got to get the best benefit for patients, okay? So traditional things that we've previously known were bad things still are bad, it's just that everybody is doing better. Does that make sense? So whereas before, if you had deletion 17p, we were worried about you relapsing within a year. Now we're using these other treatments, and half of people will still relapse, but it's 2 or 3 years. Okay? So treatments are definitely better, but we need to work out if rather than using them just on their own, we can combine them in different ways to get better effects. Of course, the other major hope of targeted therapies was that if would we get drugs that didn't have nearly as many side effects, and that would allow us to give them to everybody. What we are finding with follow-up with things like ibrutinib, that there are side effects, they're just different from traditional chemotherapy, and some of those side effects, particularly heart problems, blood pressure problems, bleeding problems, can come even when you've been established on the drug. Low blood counts related to the bone marrow, infection problems, they are definitely there. Interestingly, if this was venetoclax, which is one of the other new agents, that is definitely a harder drug to manage right at the beginning because it's a very, very powerful drug, but actually once you're on it, the side effect profile later on is really, really well tolerated. What we know from ibrutinib in looking at people who've been taking it real life throughout the UK of information that we've collected it is that up to half of people stop taking it because of side effects, not because the disease has progressed. And at the moment, at 4 years, people who are taking ibrutinib in the UK, about a third of people are still on it and having good effect from it. Okay? That's in a relapsed setting though. Okay, so that's really important to make the difference. We hope that, obviously, using the treatments in the first line may have better effects, but only time will tell with that. So at the moment, if you're on your second line treatment, we're almost ignoring this line here, and we're coming on to using the new agents. And ibrutinib has sort of dominated the market because it's a single tablet and it's easy to take. But the latest study from the Murano is quite exciting because it's got very good effects. Ibrutinib you have to take long term and you're at risk of various side effects, whereas venetoclax, the aim of that is to give you 2 years of treatment in combination with rituximab, and then you stop the treatment. So many patients prefer the idea of only having a defined amount of treatment, then stopping. Okay? And at the moment, we think that that's possibly the best approach to go for, because it's the one with the greatest effect against the CLL. But this is only just coming out, and obviously we've got to get greater experience of that and see whether that transfers through as we treat more patients. And you're not missing out on anything because you've then got the options of ibrutinib and venetoclax on its own later on. And this is the Murano study that just showed, so this is traditional style chemotherapy used in a relapse setting versus the new ways of treating, far superior. And even more importantly to you all, even in the short life, so even within 3 years of follow-up with this study, already was it showing survival benefit, not just that the disease it's stopping the growth of the CLL itself. So again, when you're looking at studies, obviously we don't just leave people when you relapse from something, we try to treat with something else, okay? So when you see a survival benefit, it shows you that using that treatment earlier is better, because even when we're offering the existing treatments beyond the one that we're trying in the trial, still it's improving survival overall. So patients are doing better from it. Transplants, the point of this graph here is basically to show that transplants in CLL have really dropped off. It's still an important thing to consider in some people, but I put this graph up really to show you it's not the answer. So at 10 years, a third of people will still be alive after their transplant from CLL. So it certainly does not cure everybody, and there's an awful lot of poisonous effects related to it. So it's really about picking out who is most appropriate. So the reason why transplants have really dropped off is because the new agents are a better option. But if those newer agents aren't working for you and you're young enough and fit enough to tolerate a transplant, and certainly if you've got some of these other tests that are showing us that you're high risk, then transplant could well be the way to go. Future. Frontline treatment with ibrutinib. There are frontline treatment with venetoclax. These trials are all now coming through and showing us benefit. But the difference is these treatments are being compared even, so they're being trialed in older, less fit patients, and they're also being trialed against less potent agents, and they're showing massive benefits. So undoubtedly, this is the way that we will move. This is the latest German trial that was just reported that's using chlorambucil and obinutuzumab, the sort of current gold standard for unfit people who, where I said to you that it might go 3 to 5 years before you need any more treatment. What we're saying with this is if you use these targeted therapies, you get an even longer and even better tolerance of the treatments, and it's working for an even greater group. So it seems like real progress in treatment of this disease. And of course, where everyone in this room will be interested in anybody who's come onto the FLAIR trial. There is evidence coming through now that's showing ibrutinib frontline is comparing very favourably and probably better than FCR chemotherapy, so it's likely to become the new gold standard. What's not known is whether it should be given with rituximab or not. Early factors are probably pointing that it's probably unnecessary, but who knows what we'll see in some extra follow-up. This is some of the data that showed there isn't a lot of benefit in adding rituximab to ibrutinib. So this is a trial comparing bendamustine with ibrutinib, and as you can see, the outcomes there are not much different whether or not rituximab is included. So there are other agents coming along. Zanubrutinib, acalabrutinib, they're all agents that are, we know that ibrutinib has some side effects. These are agents that are trying to either be even more potent or trying to avoid some of those side effects. Umbralisib is like the new I'm going to say lenalidomide, but that's not what I mean. I'm having a mind blank. Yeah, gosh, I'm talking for too long, definitely. It's the new PI3K inhibitor because basically the old one got a bad deal. It's a very, very good drug, but it got labelled with problems of infection in some of the trials, and so it's just not being used as commonly anymore. But these other agents really do look like they've got something to offer. There are agents with new targets for antibodies, but the major thing that everybody is going through is we know we've got all of these effective agents. Can we use them in different ways together to try and eradicate the disease properly? So drug combinations and how to do that is going to be the way of the future. Lastly, CAR T cells. Everybody's heard about CAR T cells. CAR T cells in CLL, it's where they started out with CAR T cells, but unfortunately getting them to work in CLL was very difficult. And they've made far greater successes in lymphoma, myeloma, and ALL so far, but they're getting there. This is a trial that's going on. CLL studies are coming to the UK, and we're working out how to take those forward around the country. It's going to be led from basically the Manchester Centre, but they will be available throughout the UK. What they've actually found is ibrutinib is very helpful in getting lymphocytes out of people that they then engineer to make the new immune system and put the cells back in. So scientists, very innovative, coming out with ideas to solve all the problems as we go along. At the moment, though, the initial problem with CAR T cells was this thing called a cytokine release syndrome, which put people into intensive care and had a lot of bad effects. They've now learned how to control that with a special drug called tocilizumab, but still one of the main problems is nerve damage. Up to 20% of people are getting severe brain damage and nerve damage related to these things, but they will find ways to make that better, okay? But what we are seeing is good responses, people going into remissions, and we hope in time it will form part of the armament to cure this CLL. Okay? So targeted therapies are being used earlier because they appear to offer greater benefit. Targeted therapies are likely to be used as first-line treatments in the future when trials which address this question report, things like the FLAIR trial in the UK. Best sequencing and how best to use targeted therapies is evolving and an area of active research. Measurable residual disease is the current way that we think we can develop ways to learn to do that. Cure may be possible for some, but for others, it's going to be about making the disease more manageable. Transplant and CAR T cell therapy is still a very toxic therapy that's suitable for some people, but not everybody. Okay.
Scott, thank you ever so much for that downpouring of wisdom.